Please allow me a moment. Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clernet, serving as the allocated session assistant to ensure a seamless experience. Clernet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clernet serves as a director partner for this event hosted by Indian Association of Community and Family Medicine. And the focus of today's session is IACFM series Valuable Insight into Common OPD Case. Now, I would like to invite Dr. Bhanupriya ma'am to proceed. Over to you, ma'am. Thank you.
Thank you, Rimpa, and thank you all the coordinators, organizers, secretary and president of IACFM for selecting this beautiful topic about the breastfeeding and navigating the challenges which are happening in the common practice. As a physician or as a gynecologist or as a pediatrician, we all are coming across various difficulties. The new mothers, lactating females, which are facing right from initiation, position, diet, and there are so many myths that what to eat and what not to eat. If there is a cough, if I am on some medication, what to go for. So tackling all these things, and this is something which we as a physician, as a doctor, as a community health worker, need to know before we have to clear any doubt about breastfeeding, lactation, nursing, positioning. Is it adequate, not adequate? How to ascertain that it is useful, not useful? If I am working, how to manage that? So that concept is extremely important for us to build in our foundation, in our mind, and later on going telling the communities that you have to continue breastfeeding as much as till 2 years, exclusive breastfeeding till 6 months, and as much as 2 years. And nowadays, WHO is recommending you can continue up to 5 years. So this is the world's purest white form of gold, a vaccine, initial vaccine, which is given to newborn. And we are, as a physician, are bound to promote it because it is cost free. It is without any adulteration. It is coming out of love. It is creating bonding between the two beautiful individuals, one who has given delivery and one who is just starting the life from the day zero. So it is very important, and we are prioritizing this. And surprisingly, it's never a surprise. All the breastfeeding weeks and their theme are curated by experts every year. We, as a coordinator, proud member of BPNI, that is Breastfeeding Promotion Network of India, we put child nutrition at the forefront. We decide that what will be the message through theme which we will be delivering to all these practitioners who are going to promote at their own institute. So this year, when we are celebrating World Breastfeeding Week from 1st of August to 7th of August, we have given a theme that we need to prioritize breastfeeding and create a sustainable support system. And sustainable support system will not happen without the involvement, awareness, creating a cadre, okay, without informing people, without creating policy changes, uh, fulfilling those gaps which are observed in the gap analysis regarding the breastfeeding, the support mother is getting starting from the day of delivery till she is continuing it, and advocating any changes which she is going across. If she is resuming duties, or if she is in a class where her maternity leaves are not permitted, how she can tackle it. So all these things, we are going to all galvanize those actions at every state of India. We are calling for the change. Every institute has to promote it as a mandatory requirement now. There are legal requirements now in certain states where if you just do not do the breastfeeding in the initial 4 hours, even after the C-section, you will be meeting an inquiry by the head of department why it has not happened, why the mother has not given the colostrum, or why she was not counseled in the mothercraft classes. So it's not just the lactation. It is a play of a mind which starts before they go into the lactation. And as a physician, we have to start preparing our mothers, our caregivers, healthcare providers, their families, okay, patient's family, all has to come forward and promote this breastfeeding. It is the blessing which nature has given to any human being. Okay, and with this, with this background, BPNI is fully supporting all the institutes who are trying to create awareness through websites, through influences, or some post, emails, online, through webinars. Recently, we have conducted all India competition for the breastfeeding posters for students and for nurses, and we have celebrated it for 8 days. So 8 days celebration demarks that it is very important. It has been important. It has been provided by nature, and we have to emphasize it by prioritizing breastfeeding in every setting, right from the delivery till the mother decides that yes, this is the right time to wean. 6 month exclusive breastfeeding is there, but we have to create a sustainable support system even if she wants to continue even after that. So when we meet all these mothers and we come across in a tribal setup, we come to know the mother is ready to give breast milk, but sometimes the difficulties are in the nutrition which mother is receiving, and that is why the role of a physician begins from the day of registry of the ANC mother. So as I think this creates a good support system, public health system, private system, maternity homes, nursing homes, all are coming together. They are celebrating this week, and they're taking this opportunity to celebrate and create awareness with the communities. So yes, with that agenda also, when Dr. Ria asked me that you will be taking up session on breastfeeding, I said I will be moderating it. And with that moderation, I just want to share my experience. All these sessions arrangements by Dr. Ria, and now we will be meeting our speaker, Dr. Anjana and Dr. Mohit. All are experts in the respective field, and they are going to guide each and every healthcare provider that how they can navigate anything which is they are finding as a difficult, even for the communication purpose, how they can navigate through these challenges to create that sustainable support, and how they can prioritize breastfeeding in every situation. So with that, let's meet our speaker for the day. Today we have for the session Dr. Anjana, and she has graduated from Government Medical College, Thiruvananthapuram, Kerala, and Madam has been gold medalist in her field. She has done MD Pediatrics, and after doing her pediatrics degree, she has continued to be part of BPNI's IYC CFF LM specialist uh, position. After that, she has completed postgraduate diploma in developmental neurology from the CDC Thiruvananthapuram, and she has been active trainer for the nurturing care for early childhood development, and she has developed modules and carrying out trainings for Sankalpa Sampurna Swasthya, that is called as IAP SSS, and she is promoting breastfeeding through baby friendly breastfeeding friendly hospital initiatives as an external assessor as well as the trainer. She has happily agreed for the session. She has shared wonderful flow of work throughout her career, and I'm sure it will be extreme delight for all those participants who will be joining today, hearing all the challenges and how as a pediatrician you are tackling them, how you are ensuring that every baby who is coming to you is getting it and is growing. It's showing a growth of development on the growth chart, the road of health, through breastfeeding for first 6 months. So I welcome Dr. Anjana, and it's now great pleasure to see you and talk with you and hear you. Okay, ma'am, you can begin, ma'am. Thank you.
Thanks a lot, Dr. Bhanupriya, for the introduction. Uh, Good evening, everyone. I I'll just share my slide and start, okay? Just give me a second. I hope I'm visible, right? Yeah. So I'm Dr. Anjana Pradeep. I'm currently practicing as a developmental and behavioral pediatrician at District Early Intervention Center in Goa. and I'm also a lactation consultant. So I would like to thank Indian Association of Community and Family Medicine for giving me this opportunity, and Dr. Ria and Dr. Mohit for all their coordination and support, and Dr. Bhanupriya for giving such a beautiful introduction and flow to the topic. Okay. So it's my immense pleasure to be with you all today in this session, because breastfeeding and breastfeeding support is something that is very close growth, maternal well-being, maternal and child bonding, as well as in impacting the society as a whole. So, in today's session, what I am planning to do is to take you all into this warmth of mother and baby bonding, and also to enable discussions which would empower each and every one of you all who is attending this webinar to be in your own ways, little ways in your practices, how to be a strong link in the warm chain of support for breastfeeding. So, as Dr. Bhanupriya has already discussed, World Breastfeeding Week is usually celebrated every year between 1st to 7th of August. And it's a global initiative. WHO, UNICEF, World Alliance for Breastfeeding Action, or WABA, and national bodies like BPNI, Indian Academy of Pediatrics, everybody is a part of it. Each and every hospital is a part of it. And this year's theme is prioritize breastfeeding, create sustainable support systems. So in my session, I would like to make you understand how at each of our levels, we can be a part of this support system. So to be a part of any support system, or to be a part of any cause, we should first believe in the cause, which I know all of you all strongly believe with the fact that you have started enrolled for this webinar. Second is to have the knowledge and to understand how at our level we can be a part of this campaign or cause. So for this, a campaign called Warm Chain Campaign of Support for Breastfeeding has been put forth. Just like the cold chain in vaccine storage that we see, like from production of vaccine to its delivery to the child who needs it, the system has to be like failure free or foolproof for this vaccine to be successfully administered. In the same way, by warm chain of support of breastfeeding, we are actually planning to give the mother, as doctor said in the previous discussion, from the day she is registered at ANC, from the start of pregnancy till at least 2 years, which is what WHO recommends, at least till 2 years to continue breastfeeding along with complementary feeding from 6 months and beyond. So our aim is to give that support system throughout pregnancy for mothers. So be in the antenatal period, during the delivery and postpartum care in the hospital, and care beyond 6 weeks. So in this, we are focusing on different actors. Okay. So we are all actors in this cause. And if each of us in our roles play the best part we can, we are all going to be superheroes supporting mothers, or super actors, superstars supporting mothers and the baby in this process. So I'll be discussing how as healthcare providers, we can support this cause. So we are all clear with the BFHI initiative, or Baby Friendly Hospital Initiative, which focuses on 10 steps for successful breastfeeding. So, first two steps are basically based on the hospital policy. I'm just running through the basics. So, hospital policies, like each hospital should have a proper system in place, which makes breastfeeding the standard of care. Okay. And it's not only to be in paper, but it has to be communicated to every staff, and it has to be periodic. As we know, in a hospital setup, there are recurrent changes of staffs and everything in each department. So every new staff member has to be periodically updated, and their knowledge in this field has to be periodically checked so that they are aware of the policies and how to help a mother. Next, when the mother starts to come to us from the detection of pregnancy to the delivery, the support that we are going to give. These 3 points is what I will be discussing in detail. So I'm not touching it currently. Then others, making the hospital environment breastfeeding friendly by promoting only breastfeeds and no other feeds unless actually medically indicated, allowing and encouraging as well as enabling the mother and the baby to be together. It's also called as rooming in. And also by ensuring that mother can understand the baby's cues and feed responsibly. And also by not promoting anything like bottles, teats, or pacifiers within the hospital campus. And at discharge, we have done everything that we can do till the discharge, and it doesn't make sense if in the family or community the breastfeeding support fails. So we should ensure with community work that whatever is being done from pregnancy till postnatal care is carried out in the society. And nowadays, with many of the mothers working and having to rejoin work after 6 months of their maternity leaves, it's our duty to ensure that this transition and carrying on breastfeeding, even when the mother is working, is a possibility for the mother. So now I would be discussing in detail these 3 steps, that is, how in antenatal care and in the care right after birth, as well as in the support during the postpartum period when the mother is still with us in the hospital, we can actually support the mother baby diet. So, first, coming to antenatal counseling. So, in antenatal counseling, we know it's a period of happiness as well as a little bit of anxiety where the mother knows that she is carrying a little one. And it is one of the times most of the women actually are ready to be attend the antenatal checkups and hospital follow-ups religiously. So this is one of the greatest opportunities that we as healthcare workers have to sensitize mothers, not only mothers, extended family members, including fathers, mother-in-laws and mothers or whoever is coming with them, to sensitize them about the importance, the significance of breastfeeding and how to establish it and sustain it. So, I would be discussing what are the most important things that we usually discuss during the antenatal counseling sessions. So, this can be done by anybody as physicians, gynecologists, anybody who is meeting the mother can do it at their level, or you can train the staff involved in the vaccinations, the TT vaccinations, or the medications that are being given. So, those staff can be trained for this. You can also have audio-visual material in the waiting areas. There are a lot of videos that are available from Indian sources also, like BPNI Maharashtra has a lot of beautiful videos which they have regarding breastfeeding, positioning, and all that. Even Global Health Media, which is a global body, also has a lot of videos in Hindi, also they have, English also they have. So these videos can be played in the waiting areas, which will sensitize the mothers and the community as such, as well as we can have flexors or boards, anything like that in the waiting areas. And depending upon what kind of setup you work in, you can either have group sessions for all the mothers who are attending the antenatal checkup on a day, or it can be individual sessions. If you have option for individual session, what I usually do is to involve the not only mother, ensure that the father is also part of it, the discussions, and also extended family members as and when possible. So by this sensitization, what we are aiming to do is give them the knowledge, the understanding of what is expected, what is the right choice for them. By empowering the families with knowledge, we are helping them to encouraging them to take informed decisions. Okay. So here I'll discuss these points mostly when they come for the antenatal follow-ups. So first is to make them understand about the importance of breast milk and colostrum. I know it is not needed to be discussed in detail here, but in simple, it's very important to have a very simple language when you're communicating with parents. Avoid medical terms and jargons. So with our simple terms, and even if you can have any audio visual support your discussions, it will be even more better. How breast milk is an optimal nutrition for the baby. How the mother's milk is made, tailor-made for the baby's needs, depending upon each period of growth. Even if the baby is born preterm, how the preterm milk is different from the term milk. How the milk in the early days, which is called as the colostrum, which is different from the later milk. So there are a lot of myths related to colostrum, because colostrum is very different from the actual expectation of milk. The milk we see is usually white in color, but colostrum is very yellow and thick, unlike the usual milk that is seen. So many are very apprehensive to give this milk. They sometimes feel that it has been something that has been stagnating in their breast for so long when they are pregnant, and they have to express it and throw it away. On the other hand, each drop of colostrum is precious. It's like doctor said, it's the first vaccine for the baby. The yellowish color of the colostrum is because it is high in proteins. Lot of immunoglobulins, antibodies that the mother is producing is being transferred to the baby through the colostrum. And a lot of vitamin A and other vitamins are also there in the colostrum. And it's also very rich in fat. It is enough. It's very less in amount, but whatever amount is available, it is good enough to fill the tiny newborn's little tummy. And it's enough to satisfy the needs of energy also, because it's high in fat content also. So this helping them to understand these things, help them to choose breastfeeding. Next is also just brief them about the breast changes that happen in pregnancy, because many will be preemies, some are in their early 20s, many of the mothers who come to us. So they might not be clearly available. And in a country like India, open discussions about reproductive health is not that common. So it's always better to feel that they might know and like tell them rather than waiting for them to ask at many times. So breast changes in pregnancy, like you can tell that sometimes your breast might become larger, it might become heavier, there might be some tenderness in the breast. Sometimes you can see that the veins or the blood vessels that is over the breast sometimes becomes enlarged or becomes more visible. And also the nipple areola complex becomes little enlarged and dark. And certain small tubercles start appearing around the areola, which is called the Montgomery tubercles. All these things are very important for the lactation. And also brief them about the stages of lactogenesis, by which I mean, so in lactogenesis or milk production, parents should be aware that milk production is not something that starts after the baby is born. Milk production starts much before that. It starts from around 6 weeks and it's almost complete. The secretory differentiation or the first stage of lactogenesis is complete by around um, 20 weeks of 26 week of gestation. Why it is important is even preterm babies, mothers of preterm babies can actually produce milk. Milk production is the apparatus or the functional system is in place. And the second stage of lactogenesis actually starts after the baby is born. So when in pregnancy, the progesterone levels are high, usually the milk production is suppressed. Only little colostrum gets formed. After that, once the progesterone level falls post expulsion of placenta, that is when prolactin kicks in and the milk production actually starts. That is why initial 2 to 3 days, mother's milk volume is naturally less. And by 3 to 5 days, depending upon mother to mother, there is copious milk flow which starts. That is when the actual um, secretory activation happens. And post this by around 9 days, galactopoiesis stage comes. And what is the importance of this stage is, this stage is more like an autocrine at an autocrine level. That means, so it is based on demand and supply. So more the demand at the level of breast, more breast milk is produced. So it's very important to sensitize the mother that more you feed, more milk will be produced. More you bond with the baby, more milk will be produced. Also, these hormones that is important in breast milk production has a lot of impact from maternal stress. So being well fed, mother being in a good mental status is also very important for the baby's well-being and breastfeeding. This is the basic physiology that I usually discuss in antenatal classes, and also discuss about WHO recommendations. What ideally are they supposed to do? They should know that whether it be normal vaginal delivery or cesarean delivery, if the baby is otherwise stable and does not require any resuscitation at birth, and the baby is born after 37 weeks of term, they are supposed to get their baby with them, and they can actually ask for skin to skin with the baby in the birthing table or the cesarean cot for 1 hour uninterrupted. And breastfeeding is supposed to be initiated within the first hour of life. despite whether it is a normal delivery or cesarean section. And the mother is supposed to feed the baby exclusively with breast milk for first 6 months of life. And after that, 6 months of life, now, previously the word weaning was used. Now it's no longer used. We use the word complementary feeding. That is, the feed that we are going to introduce has to complement breastfeeding. Breastfeeding has to continue, and along with that, complementary feeds, adequate and safe and in adequate amounts for the significant age of the baby, has to be given till 2 years at least, and beyond if the mother and the baby decides to do so. So, along with that, we also have, it's always good to let them know about different positions. Our previous common position that was being said was cradle position or the cross cradle position. But now there are different other positions like football position, which you can see in the first diagram, or the laid back position, or the lying down side lying positions. All these positions can be used for breastfeeding safely. Only the positioning and latching has to be shown, or if their mother has any concern, it has to be dealt with. Football position specifically becomes very helpful when you're feeding a baby, twin gestations, twin babies, or if the mother's breast size is very big. Laid back feeding becomes very helpful when the mothers, like for CS, post CS mothers, and even side lying is very comforting for the mother. There are a lot of videos. I'm not playing any of these videos. You can please, these are freely available videos on the YouTube from Global Health Media and BPNI Maharashtra. Even Indian Academy of Pediatrics has a lot of videos which can be used for your audio-visual purposes in your workplace space. Next is, we are focusing on responsive feeding. What is responsive feeding? Previously, it was like baby has to be fed every 2 to 3 hours. Now, what we say is it has to be demand feeding. Whenever the baby demands, the baby has to be fed. Okay, and how does the baby demand? Baby doesn't ask, right? So this is first month of life is actually the most difficult part for the mother and the baby, because mother also sometimes does it. She's new, especially for the primary mother. She doesn't understand the cues of the baby very easily. So it is our responsibility to make them understand these early cues and start breastfeeding when the baby is showing the early cues. As you can see in the diagram, there are three different cues. Early cues, when the baby is telling that I'm hungry, it will be like just moving, opening the mouth or turning and seeing whether the mother is there. Or mostly what happens, the mother's breast, Montgomery tubercles actually produce significant scent that actually is helps the baby to root towards the breast. So it is very even the newborn baby can, even if placed at mother's chest, can actually breast crawl and reach the breast and feed. That reflex is very strong in the healthy newborns also. So this is the first early cues. This is when the baby is telling hungry. The baby is responsive and most calm when you can attach the baby to the breast at this point. Mid cues is when the baby is telling, I'm really hungry, please give me, I can't wait anymore. This is like a little bit more stretching, increasing of physical movement and getting hand to mouth. Whereas the later cues is like baby is fed up. I have told you multiple times, I've indicated, now I can't. So then the baby is crying, or baby is agitated, or baby is turning red. So at this point, if we try to attach the baby to the breast, it's very difficult for the baby to get a proper latch. That can lead to difficulty in latching, positioning, painful feeding, and all that. So when the baby is showing late cues, also tell the mothers first to calm down the baby by cuddling or skin to skin contact. And then slowly, once baby calms down and reaches the stage 1 or stage 2, to put the baby back to breast. Also, discussing about attachment. Attachment is very important because only if the baby, as we know, the breast milk is usually located under the areola in the lactiferous tubules. So, and the ducts. So, if the baby presses on that, that is when the milk comes out through the nipple. If the baby attaches only to the nipple, you can see in this diagram what happens is, in this wrong attachment, the baby is sucking onto the nipple. At this point, the mother's nipple is like brushed against the hard palate, which actually injures the nipple. And this is one of the most common reasons for sore nipples. So and helping them understand proper latching. So when the baby is showing early or mid cues of hunger, then the baby has to be brought to the breast. The baby's body, the head, the body is to be in straight line. Baby's tummy touching in any of the positions. Baby's tummy is touching the mother's tummy or the body very well. And then bring the baby's nose towards the nipple. Nose towards the nipple so that baby can open the mouth and take a full scoop of breast from below so that most of the areola below goes inside the baby's mouth and only a tip of areola on top has to be visible. And the baby's mouth should be wide open. So I think this is something that we always discuss, but I'm reinforcing it again and again because one of the most common reasons for difficulty in breastfeeding is because of poor positioning and latching. Next, coming on to the guidelines that at birth, we saw antenatally how we can support a mother. Now we have counseled the mother. She's all very set and she's ready to breastfeed. And if our hospital system fails her, then it is going to be a tragedy. Because now, if she can't breastfeed, she'll be more upset. Okay. So we should ensure that our hospital system promotes early skin to skin care as well as early initiation of breastfeeding. What is the recommendation is all term babies 37 weeks and above and vigorous. By vigorous, I mean babies having good muscle tone and crying and all well, doesn't require any resuscitation, has to directly go for skin to skin. There should be delayed cord clamping at around 1 minute. And then in the cot itself, actually the breastfeeding has to be started. So you can, if here breast crawl can be tried also. Many hospitals do that and they have been successful. Depending upon the what we usually suggest is at least 1 hour of skin to skin contact, and every 15 minutes this mother baby diet has to be checked by somebody who is trained in this. So as gynecologists or neonatologists or pediatricians, we might not be able to stand by the side. So it has to be ensured that one of the hospital staff, it can be nurses or ANMs who is trained for this purpose, is near the mother to check on the baby's color, breathing, etc. once every 15 minutes. Next, all the late preterm neonates also from 34 weeks to 36 weeks plus 6 days, if clinically stable, they have the sucking and swallowing reflex in place. They can also directly breastfeed. For them also, if they are stable, skin to skin contact and early initiation of breastfeeding has to be started in the delivery room or the CS table itself. For sick neonates who require resuscitation or it's a very preterm baby, less than 34 weeks, who needs extra care in the ICU, then resuscitation will be our prior importance. And then as soon as the baby is stable, our aim should be to start breast milk in any form, in the sense like by direct breastfeeding or by tube feeding or by spoon feeding, whatever form it is, directly or express breast milk as early as possible, and skin to skin too as soon as the baby is hemodynamically stable. That is what we do as kangaroo mother care in the NICUs. So from this, let's be advocates of immediate and uninterrupted skin to skin contact and early initiation of breastfeeding. It sounds very simple, but when you start applying it in practical setups of sometimes the busy hospitals in our Indian setups, it is not easy. It's very important to have a very strong willed reader who can make it happen. Next, how can we support mothers with breastfeeding when the mother is in hospital? So this is when actually all those things we have taught the mother, actually we get a chance to practice it clinically, to show her positioning, suctioning, like attachment, what is like normal suckling and all that. Okay. And helping mothers with common breastfeeding problems. So here I'll be discussing about major queries that you usually get during the initial days in hospital. Most common query that we get is my baby getting enough milk? All mothers want to ensure that their babies are getting enough milk. And this is a common question. How do we assess if the baby is getting enough milk? What I say is usually after the first 48 hours of life, you start counting the urine. If the baby is passing urine around 6 to 8 times per day, maybe sleeping well after feeds, and then babies gaining weight adequately, by which I mean 25 to 40 gram per day. So here, the natural pattern of weight loss in babies is that initial days, there is a dip from the birth weight, which the baby is supposed to be, it should not cross beyond 10%. If the baby is born with a specific birth weight, the weight loss should not be more than 10% of the baby's birth weight. And by 10th day around, baby has to regain the birth weight, and further on, around 25 to 40 gram per day, or around 125 to 250 gram per week is the adequate weight gain for a term baby that we're expecting. If this is happening, then you can be sure that the baby is gaining weight. Also give some advice about the breastfeeding, that you have to feed your baby well and good from one breast, for like, so that the fore milk, which is more rich in lactose and fluids, is also emptied. And after that, the hind milk, which is rich in fat, which is essential for weight gain, is also reaching the baby adequately. And then only if the baby is still hungry, you can offer the other breast. Next, common other concern is pain while breastfeeding and sore nipples. As I discussed previously, most common cause for pain while breastfeeding or sore nipple is because of suboptimal positioning or inappropriate latch. Most of the times, once we actually go in person and see the mother latching and positioning and guide them with proper latching, and you have to like try out different positions. One mother might feel it comfortable with cradle hold, but other mother might benefit from football hold, and it varies from mother to mother. So try out different positions, ensure that the latching is appropriate. Mostly this pain at breast or sore nipple is gone. When the nipple is sore, we don't have to stop breastfeeding from that breast. Only the latching has to be made correct. And after breastfeeding, hind milk actually can be applied onto the nipple areola complex, and it can be left to air dry. This itself will heal the sore nipple in most of the times. Another common cause is because of fungal infection, where the nipple is red. And when we see like this in the baby's mouth also, we can see white patches or candida infection. This has to be treated with local antifungal or clotrimazole cream, both for the mother's nipple as well as the baby's mouth. And some other reasons for rarer but can be there is, it's called tongue tie. Tongue tie is when the floor of the tongue is attached to the floor of the mouth, or the frenulum is very tight. So this is very rare. It has to be assessed for if after correction of latch and infection, or if anything is there, still the baby is not able to latch properly. These kind of things has to be ruled out. And if at all needed, surgical correction like frenotomy can be done later. Next, common is breast engorgement or mastitis, which is now, as per Academy of Breastfeeding Medicine clinical protocols, called as mastitis spectrum. So this what happens is, for some reason, the milk production is much more than what is being emptied from the breast. The milk collects there. There is inflammation because of the milk that is collected. It can lead to some ducts narrowing and getting blocked. Once a duct is blocked, more milk accumulates behind that. That can lead to more inflammation, causing inflammatory response in a larger area of the breast. Sometimes this inflammatory response can get infected. It can cause bacterial mastitis, and later it can also present with abscess. So current recommendations for all these spectrum is, first is to assess. Most of the times the milk secretion is, the milk drainage is not proper because of improper positioning or improper latching. That has to be corrected. Also see to it that we are not unnecessarily prescribing galactogogues. Many times like medications like metoclopramide, domperidone, or some galactogogues are prescribed without randomly. So that has to be seen if that is a reason for this increased production. And then ask them, current protocol is to give the mother, ask the mother to cold compress. Okay. Feed the baby, continue feeding the baby, not to over empty, because as if you try to over empty to empty the breast, what happens is more milk will be produced. So feed the baby as per the baby's needs only. Continued cold compress. Give NSAIDs for inflammation, as well as paracetamol for pain. And if bacterial mastitis is there, it has to be treated with antibiotics. Suppose this inflammatory mastitis and pain is not reducing by 2 days of your conservative management, then antibiotics has to be started. And if abscess is there, it has to be drained, and antibiotics has to be continued for 10 to 14 days. All this while the baby can be breastfed from the same breast also. There is no problem with that. Next, special situations, feeding of low birth weight infants. As I discussed, babies more than 34 weeks, even though they are low birth weight, they have mature sucking pattern and more coordination between breathing and swallowing, and they can be breastfed. 32 to 34 weeks, these babies have mature sucking pattern, but their swallowing and breathing coordination is not good enough. So they might be started on with express breast milk with spoon or paladin. 28 to 31 weeks, these babies, for them, the sucking is also not completely developed. So sucking bursts, some bursts of sucking they get, but there is no coordination between suck and swallow. So these babies are usually started with orogastric feed. This again with express breast milk. Babies less than 28 weeks, their reflexes of sucking, swallowing have also not developed, as well as their gut motility and maturity is also not developed. So they are usually started with intravenous fluid. Now, how to go about later? Here, whatever the child's condition is, whether it be preterm, whether the baby is having asphyxia, hemodynamically unstable, our norm is to start early enteral feeding once the baby is hemodynamically stable. By that I mean, once the baby's blood pressure is stable and baby is out of shock and all that, even ventilated babies can be started on enteral feeding. When we start, we don't start the full amount. We usually start with something known as trophic feeds. Trophic feeds is minimal feeds, like somewhere around even 0.5 to 1 ml per feed. Then to see, this actually helps in gut maturity, especially in preterm babies. It helps all these immune factors present in colostrum and milk helps in the gut maturity, prevents necrotizing enterocolitis also. So sometimes even for preterm babies, we do something else known as colostrum swabbing, wherein we are not feeding the milk, we are only swabbing the oral cavity with colostrum, okay, with the like clean fingers or gloved fingers. Then express breast milk is the first option for feeding all these babies. We also call it as mother's own milk. Many of the hospitals have milk banks now, which if mother's own milk is not available, next best option could be pasteurized donor human milk or PDHM. And once the baby stabilizes, it's an ongoing process and depends on the child to child. We look for feeding cues in the babies. As professionals, we have to assess each child. Is the child now ready? Can I progress from IV fluids to tube feeds? Can I from there shift to spoon or paladin feeds? That growth actually is varying from child to child. And what has been seen that this procedure that we call as non-nutritive sucking. This is a process wherein the baby is allowed to suck. Mother expresses the mother's milk from the breast, and when the breast is empty, babies like even 32 weeks who are not ready to breastfeed directly completely can be made to suck onto the breast which is empty. Sometimes we also drip small drops of milk from top. This actually helps the baby to learn that sucking and swallowing. And uh, only indication in preterms where we actually stop breastfeeding is when the baby has necrotizing enterocolitis, which is an entity only in preterm babies. Here we spoke about the babies. The mothers of babies who are not well at term are also in stress. It's our duty to support them as well. So here, as we discussed about skin to skin care and early breastfeeding initiations for a mother of a healthy neonate, it's also important to tell the mother of a neonate who is at present in an ICU, might not be able to take direct breast milk, the importance for early expression. Same, like as early as 1 to 6 hours, the mother can start expressing. Save the colostrum, store it in proper places. Okay, so most of the hospitals which have milk bank, help the mother to store the colostrum in the milk bank, or else it can be stored in individual refrigerators also. And ensure that even if the baby is sick, mother has proximity with the baby. Allow an ICU visits. Give regular updates to the mother as well as the family. Promote kangaroo mother care. As we can see in the diagram, where the baby is placed on the mother's chest, bare chest, bare chest facing the mother's bare chest. And mother and baby are ideally supposed to sit for at least 6 to 8 hours continuously in a day. This actually promotes the baby's growth, development, as well as milk production in the mother. Promote family and paternal participation. KMC or kangaroo mother care, it can also be done as kangaroo father care or even kangaroo grandfather care. Anybody who is willing to participate in that, make them participate. The thing is, we are going to send this baby back home. So they have to be empowered to take care of the baby by the time they are discharged. That is the aim of this NICU stay. Make the parents or family members active partners in neonatal care. And also, discharge and follow plan has to be properly communicated. When to come back, what to look for, how much weight gain, what supplements, everything has to be clearly explained before discharge. Another specific condition is cleft lip or cleft palate. It's common congenital anomaly. Different varieties are there. It can be just cleft lip. It can be unilateral cleft lip. It can be bilateral cleft lip. It can be cleft lip associated with cleft palate and different degrees. So generally, breastfeeding can be a difficult scenario for children with cleft palate and cleft lip. And it's depending upon what level the child is in, the difficulties, and also depending upon, see, this being a very cosmetically difficult thing for the parents to accept, sometimes a denial can also affect the mother baby bonding. So it is very important for us to be very non-judgmental, supportive to mothers who need help. Currently, the management part is breastfeeding is decided based on child to child, and sometimes child with cleft lip or cleft palate can have other congenital anomalies also. It also depends upon that. We can start breastfeeding by direct breastfeeding if it's just unilateral cleft lip also. Sometimes we can even start Paladay feeding, or sometimes it is OG tube feeding. And this is a multidisciplinary approach. Pediatricians, pediatric surgeons, and even the dental team, they usually provide something known as a naso-alveolar molding, which is the thing that we can see in this diagram. So that is usually started early. It has to be revised also. Like usually the parents will have to come once in every 2 weeks, 3 weeks, like that to the dental department, where they will, based on the baby's growth, they will adjust the size of this naso-alveolar molding. And then by 6 months to 12 months, the cleft lip is corrected first, and later the cleft palate is corrected. Now, coming on to breastfeeding from 6 months to 2 years and beyond, our importance role is to, like we explained about the importance of breastfeeding in the early period, we have to tell about the importance of breastfeeding in this period. Even when you're starting complementary feed, what is the role that breastfeeding plays? The thing is, the breast milk actually is very dynamic. It changes across the baby's lifespan. So when the baby is a toddler, when he's moving, he's falling, his muscle is growing, actually the way casein content ratio of the breast milk also changes. There is more casein, like 50 to 50 it becomes, way to casein ratio becomes. Actually, this casein is helping in muscle repair and all that. And even antibodies, after the colostrum, it is a toddler milk which has the most amount of antibodies. It's very important for the baby. The baby now is going to move around, put things in the mouth. All these helps. Complementary feeding advice has to be clearly given, because at 6 months, baby is actually developmentally ready. Sitting, most of the times, like baby's head control is there. Baby can sit, baby can handle things, take things to mouth. Baby is actually developmentally ready. Introducing right amount, texture, and quantity of complementary feed at this point can save us a lot of trouble. Like parents coming and telling in 2 years, 3 years, my child is now a fussy eater or a choosy eater. This can be prevented if complementary feeding is properly introduced. Next main query in this age is, how can I breastfeed if I join back work? Here, this is a very common scenario now. So it's our responsibility to support the working mother. Sit with them to explore available options, all the options. It can be like, what are the options that you can get from your workplace, like 2 days work from home, 3 days at place, any of those options. How are you traveling? What is the support at home? All these options and counseling we might have to help the parents with, and ensure that the workspace is breastfeeding friendly. Now in India, any company which has more than 50, any office which has more than 50 employees is supposed to have a breastfeeding room in their premises. Breastfeeding room is where the mother can be a creche. Mother can take a baby and breastfeed also if the nanny is coming, or it can be a place where she can express the breast milk. And it is also supposed to have a refrigerator wherein she can store this expressed milk, breast milk. So our role is to counsel the mother to let her understand different ways how she can express. It can be, see, hand expression is not possible when you have to express such great amounts for long periods. So mostly it is like breast pumps. What level, sometimes it's provided in the workplace, how to sterilize it, how to use it, how to express breast milk, how to store the expressed breast milk. Mostly what we suggest is mother can express once every 2 to 3 hours and store the milk, whatever is coming, in the refrigerator compartment. And she can also have this, like the vaccine carriage boxes we have, there are also carriage boxes with ice tray in it, in which the mother can actually carry the breast milk back home. And how to store this breast milk that can be fed on the same day, that also has to be, this is a storage protocol that we usually discuss with mothers. So expressed breast milk, this is a CDC guidelines from USA. So here what they're saying is the breast milk that is pumped immediately, if you're keeping it out in the room temperature, it can remain like that and can be used up to 4 hours, 4 to 6 hours. But in a country which is like warm and humid country like India, it's better to keep it at 4 hours. Then if you're keeping in the lower compartment, the refrigerator compartment, we can use it up to 4 days. If you're keeping in the freezer compartment, then you can use it to somewhere around 4 to 6 months best, and it can even be extended up to 12 months. And how to bring this milk back to room temperature, that's what we call as thawing. Usually what is advised is, either suppose the milk is in the freezer compartment, the mother wants to use the milk during the morning, she's deciding to keep it out, she can keep it out at night from the freezer to the refrigerator. So there it can be thawed over 12 hours and it can be used in the morning. Or suppose if you're using it like little more immediately, you can keep it out in the morning, thaw it in the room temperature, or you can thaw it in in a water bath, which contains lukewarm water, very like room temperature, little above, not more than that. You can't heat the milk or uh, keep it in warm water. Okay. And whatever, so suppose you have thawed a milk, you can't refreeze it. It has to be used within 1 to 2 hours if it is kept outside once the milk is thawed. So these kind of things might need to be counseled to the parents. Now, before I end, let's end with some fun of breastfeeding. By 6 months to 2 years, most of the mothers are pros in breastfeeding. They enjoy breastfeeding. They are confident about it. Most of the babies also have become pros. They will start all gymnastic positions for breastfeeding. And most of the concerns that come with in this period is that sometimes parents notice that during changes in patterns of breastfeeding, a baby who was breastfeeding very well now is not like breastfeeding, like it's like 30 minutes feed has become 5 minutes. Baby gets up at night for multiple feeds. These kind of small changes in the pattern of breastfeeding or sleep can happen during growth and developmental spurts. Suppose at 10 months, the baby is now going to like from crawling, she's coming to stand position. That is a developmental spurt. During these spurts, certain changes in breastfeeding pattern can be seen. It is usually very temporary and short lasting. And my baby gets very distracted. They are very exploratory. They have reached a stage wherein they know that they can manipulate the world, they can see, they can explore. So many a times they experiment with the mother, they experiment with the breast also, they experiment with the mother's limits also. They get very distracted when they are feeding. So I generally tell mothers of 6 months to 9 months, that age, feed them in a little calmer place, not when everyone is around or his toys are around. Take the baby for breastfeeding to a specific place. This also helps in setting a pattern. What happens sometimes, I have toddlers coming in that telling that now he has grown up, he wants me to breastfeed anywhere, anytime. We are out for a party, that time he wants it. It's not that he is hungry, he wants it, means he wants it. So these kind of concerns can later be little like if you set that pattern, breastfeeding is going to happen in this specific place. This is where we go. And during breastfeeding time, it's only mama and you. Those kind of concepts, if it gets into the child early, it can be effective later also. So another question is, oh my God, did she just bite me? Biting is also a common thing that comes as a concern for mothers of babies, toddlers, especially like from the teething age, 9 months to 12 months. So ensure them that it's just a temporary phase mostly. The more you respond with very animated response, the more the baby is going to do it. Gently tell that no, stop the breastfeeding, like put your finger, detach, and then stop the breastfeeding for a minute or two. Nicely tell them that no, you don't bite, and then you reattach. Slowly, if that is done consistently, most of the children get over this phase also. So, with this, we come to an end of this session. I hope all of you all enjoyed the session and it was beneficial for you all. And as I spoke in the beginning, let's all contribute in our own very little ways in our own workplaces. Like little drops make a mighty ocean. Every little work, every little voice is very important in breastfeeding. And if we all stand with the breastfeeding mother, breastfeeding will work magics. Thank you, and questions are welcome.
Definitely, madam. You have very well summarized that each drop of breast milk, which will be there from a mother's breast, is going to provide so much of nutrition, which will be blessing to a society to raise such a beautiful and strong community to when we are going into the adult phase, they will find that immunity, they are staying away from the non-communicable diseases, and they're building up their immunities. So definitely you have summarized everything, starting from the ANC education, mothercraft classes, then how we can utilize how we can differentiate colostrum and breast milk, how to have a proper attachment, how to identify the hunger cues, and further you have some concluded with the milk bank and how to store the breast milk. So definitely it has been wonderful hearing you and all those pointers. I'm sure every practitioner who has joined today has taken it, and now the session is open for the question and answer. So participants are requested to write their questions in the question answer box or the chat box, and we will try to take them one by one in coming next 2-3 minutes. Yes. So as participants are writing, I will also just promote the BPNI initiative that we have developed a Shishu Poshan app. This is a mobile friendly, digital device friendly, handheld device friendly app. So any healthcare professional can visit this Shishu Poshan app. It has been available in at least 7 languages. And this Shishu Poshan app demonstrates various positions, any query related with the biting or some pain or use of galactagogues or use of breast pumps, how to use it, how to store it, where are the Hirakani Kakshas, that is the breast cradle rooms or breastfeeding rooms, which have been made available and made mandatory at bus stops, railway stations, in the hospitals, at various public institutions, how they can utilize it. So this Shishu Poshan app, if someone wants to visit, they can download it. It is free of cost, and your suggestions will also be welcomed if you have any suggestions regarding the improving the user interface for the same. So do we have any questions, Rimpa?
So, ma'am, I've just checked the question box. There is no question as of now.
Uh, that means, yes, that means there are only two things. Only two things. I tell my postgraduate students, undergraduate students that if you don't have any question, that means you are very thorough with the subject. You have understood each and everything beyond the expertise even of the speaker. And the other thing is you have not paid attention if you don't have any question.
Okay. So I have just received one question in the end.
Yes.
Somebody took it
Just
very seriously.
just allow me a moment, ma'am. I'm just
Sure,
posting
sure.
it. Yeah, just posted a question.
Dr. Vimal has asked frequency of breastfeeding in a day during daytime and a night time. So I think Anjana madam has given up answer that it should be in the initial days, it should be feeding on the demand. But definitely madam will answer better. What will be the pattern? What will be the frequency? So madam, it's up to you now. Please
Yes,
try
ma'am.
to.
So frequency, as has been discussed, it's mostly demand feeding. But at this point, we should also ensure that we speak about night feeds, because night feeds are very important for the maintenance of lactation. Prolactin, which is a milk secreting hormone, has a circadian rhythm. It's produced more during the night. So it's very important that we communicate it to the parents. At least 2 to 3 feeds at night is also very important. So mostly most of the babies who are feeding, no, they will ask for milk once in every 2 to 3 hours, always, especially in the initial days. It's only from around 3 to 4 months they might start sleeping for 3 to 4 hours altogether continuously at night. So till then, this is the usual pattern.
Yes, okay. We have some appreciation post from Dr. Srishti. She's saying this has been wonderful session. Okay.
Thanks,
So
Dr. Srishti.
Dr. Vimal, one more thing, because you are a doctor, healthcare professional, the feeding pattern also depends on the stomach size. In initial days, the stomach size is very less. So that's why they require multiple feeding even during the night time. Okay, and as we grow together, baby also starts metabolizing it better, their stomach size increases, and sometimes the frequency drops down. But there is, as madam has shown beautifully in the slide, that there are growth spurts which are going to happen, and that time definitely the baby will be more clingy, more demanding, more cranky, more fussy for the breast milk. So it will be always be on the demand and how the baby is performing. And one more thing, since you have asked about the feeding pattern, always the feeding pattern should match with the urine output. So if your baby is producing enough amount of urine, passing 5 to 6 uh, urination frequency, then that is indicating, and also growth, weight, weight increase, weight is maintaining, it's within the growth chart, then definitely it is receiving good amount of milk, all the foam milk, hind milk has been received, and it is able to process it. Okay, so I think Dr. Vimal, your query has been addressed. Yes. One more question we have from Dr. Shalu Mittal: should we stop feeding from the side and until when if galactoscale formation occurs? So, madam, if galactoscale formation has been occurring, what should be the feeding pattern? How to go ahead with this condition?
No, the stopping of feeding from the same side is not usually advised, but overfeeding is not. Like sometimes trying to express completely empty the breast might not work, so that is not advised. But continuing the feeds with other management that is going on, as I said, no, like NSAIDs, cold compress, and all those things going on side by side is what is advised. Unless the mother is feeling it very uncomfortable to feed from that side, we can advise expressing, hand expressing and pumping and discarding also. Especially if the baby's latch is not proper, or something like that is ongoing. Case to case basis, you can decide like whether to pump and um, feed the baby with that milk, depending upon the case. I
Yes,
think
I think Dr. Shalu, madam has addressed your question. Now we have one more question from Dr. Om Prakash. He's asking if breast milk secretion is problem, when it can become normal, what will be the maximum time duration?
ma'am,
Yes.
I didn't get the question.
The question is, if breast milk secretion is problem, when it can become normal, and what will be the maximum time duration which is required to become it normal? So
Breastfeeding secretion, I think it's less secretion of breast milk, or
yes, I think he is going on that track. If secretion is problem, I think the common complaint which we get in OPD, माँ मेरा breast milk नहीं बन रहा है. So it is something like that. That mother is not producing enough milk or secretion is not there. He is going on
yeah.
that track. So let's see.
So, so I think, ma'am, like it's most of the times it is a perceived inadequacy than actual inadequacy. So our counseling, making them understand like why we feel the milk is adequate is one thing. Next is again and again telling if actually the milk is less, positioning, latching, correction, and all that has to be done. And sometimes very rare places, insufficient milk supply is also there, but we will not put it at first. That's what. So that's we try all this like a diagnosis of exclusion, what we call it, no? Like
Yes,
that it is.
yes.
So we first try all these steps. And with this, I think like depending upon case, mostly if you correct the latch, position, maternal well-being, mother-baby bonding, in a week's time, it's all back in normal kind of.
Just to add on the answer, Dr. Om Prakash, the secretion problem are mostly very rare. And the secondly, more the latching, more the breastfeeding, the better is the secretion that has been observed in various meta-analysis. So even if the in initial days mother finds it very difficult to feed, or if she is complaining that secretion is not enough, breast milk is not enough, my child has been crying a lot, I have to give top feed. No, that will be more worsening the condition. She has to latch again and again, and the releasing hormone, letting down reflex will settle down, and the bonding will develop, and automatically secretion will start. The maximum time duration can vary case to case, but usually from the meta-analysis, it has been found that within 2 to 3 days, even for the primary mothers, secretion comes to routine and normal.
Thanks, doctor.
Okay, and we have one more question from Dr. Srishti Singh. She's asking, where can I get more information about breastfeeding and other conditions? She has asked that where can I read about it more?
I think there are BPNI also has courses. I think you can talk about it also.
Yes,
There is
yes,
training.
BPNI,
Yeah.
yes. Uh, Breastfeeding Promotion Network of India, which is a all India associations for pediatrician, family physicians, community health workers, or any healthcare provider can join this membership. And we run 6-week course, 4-week course regarding the breastfeeding and difficulties. And more information definitely you can find on the, since you're a doctor, you can find on PubMed, Scopus, Dodge, various articles, textbook, and various sites, materials published by the government of India. And then there is a MA guidelines which are been recently published. So you can utilize multiple of sources, and the resources will be available to you for further reading. And yes, textbook. Why should we should forget textbook? IAP textbook, our undergraduate textbooks from like community medicine. They teach breastfeeding for at least like 6-7 pages. So definitely you can get more information from that. Dr. Shalu Mittal has given appreciation that this has been a great session. Thank you, Dr. Anjana ma'am.
Thanks.
And yes, Dr. Vimal sir has also shown appreciation for the session. Thank you, Anjana ma'am.
Thanks, doctor.
Okay. So moving ahead,
Thank
now we have Dr. Mohit for a session on the quality improvement initiatives for the breastfeeding. Dr. Mohit has done MD Community and Family Medicine, and after his post graduation, he has led multiple research projects, and notable research projects are from the ICMR, where he has worked for the quality of intrapartum and immediate postpartum care of mothers and newborn, where he has carried out implementation research to catalyze the performance of Lakshya program. And definitely Lakshya program, we are all aware of, it is a quality improvement initiative of the government of India, where they are trying to improve the public health system by bringing some kayakalp aspects, by strengthening the newborn corners, creating NICUs, and so many things. So that has been extremely beautiful work by Dr. Mohit. Dr. Mohit also has worked for the newborn care, especially in the field of vaccines, where he has carried out research on the Jinvac and JE vaccine administration for the Japanese encephalitis. He is a complete package. He has multiple projects in his name, and he has received various notable honors. He is a member secretary elect for the ISAFM association. So I welcome Dr. Mohit Bhardwaj, and I request him to start the session regarding the quality improvement initiatives for the breastfeeding.
Thank you, Dr. Bhanupriya, for such a warm welcome. So, like, I'll not waste much time and just start the presentation. So, I will be discussing the improving the breastfeeding outcomes, like simple interventions, and how to last them as a sustainability is also one of the point for the theme of this year's breastfeeding week. So I will be categorizing my presentation into three. Like first, I'll briefly discuss about the problems, then intervention, and how to sustain them for longer time duration for a better breastfeeding outcomes. So understanding the gaps, this is an like important thing. Like to understand the challenges, which already I think has been discussed by the Dr. Anjana, but we'll quickly move it like low exclusive breastfeeding rates. This is a like problem, and I will be discussing in the next slide about the rates of the breastfeeding across the nation. And there are early initiation issues, like despite the WHO and UNICEF recommendation of the exclusive breastfeeding rates at 6 months, the results are still suboptimal. Like various problems are there, which can be like related to the mother, like baby cries a lot, baby sleeps too less, and number of which already has been covered by the Dr. Anjana. Some are like healthcare facility related barriers, which lead to delay in the early initiation. Some myths and like practices like pre-lactal feeding, or some system level barriers, like already some policy and programs like IMS Act is there, Infant Milk Substitute Act, which is not correctly implemented, and there is a weak enforcement, which is leading to effect of these breastfeeding outcomes and the poor breastfeeding practices. So this is the situation as per the NFHS 5 data of the breastfeeding. Like 89%, as you can see, is the institutional deliveries. The mother are giving birth in the institution, and 40% only are able to initiate the breastfeeding. So this tells the huge gap which can be related to the healthcare facilities, maybe which is causing the delay in the initiation of the breastfeeding. And when we talk about the exclusive breastfeeding rate, they are just 63%, still around like 30% lagging behind the institutional deliveries. So this highlights a critical missed opportunity for the newborns who do not receive their first inoculation against the protection against the death and diseases. So I'll just quickly quote some a study which is published in the PubMed about the neonatal mortality and the relation of the EABF, and this will compare to the infants who initiated breastfeeding within the 1 hour. So infant who initiated breastfeeding within 1 hour, and compared to those who are initiated after 2 hours, but within the 1 day, that is before the 24 hours, they are having about 1.4 times greater risk of the neonatal mortality. And if it's delayed after the 1 day, that is 24 hours, the risk increases to about 2 times. And when we compare it to initiation after 4 days, the risk increases further, crossing the twice the risk of the neonatal mortality as compared to those who initiated within the 1 hour. So you can see like how important is the this breastfeeding, exclusive breastfeeding, and the early initiation of the breastfeeding. So we as the like primary care providers and family physicians, they have a very important role in the breastfeeding support. Like immediately after the 1 hour, there is a overlap of the pediatrician, nutritionist, and the obs gynae specialists are there. So this is a very good opportunity to deliver the breastfeeding support to the mothers, and proper counseling techniques and follow-up strategies can be used, which I will be discussing in the upcoming slides, like how on which point should be more focused to deliver these counseling sessions. And interdisciplinary collaboration between these pediatricians and lactation consultants should be there for the breastfeeding support. I will be discussing the breastfeeding techniques also. And one more point which I want to emphasize here is, rather than bombarding mothers with the knowledge about the like techniques, about the problems, we should help them in changing their behavior. It should not be just giving them the knowledge. It should be how much they have learned. This should also be checked. So this is a very well chart. Many of you might have seen this. This is from the MCP card, which is issued by the Ministry of Health and Family Welfare. So this is excellent. I'm not going into detail of the whole of this maternal and child protection card, and it's already translated to the local languages as per the state norms and Hindi. So this is the part which is given in the MCP card about the breast feeding practices. like about the need of the breast feeding of the breast milk, about the importance of this colostrum, about the what are the benefits of this breastfeeding, and how it protects from the various illnesses also, and when to refer to the healthcare provider, whether ANM, ASHA, or Anganwadi worker, if they have any problem related to the breastfeeding. So this is one chart which is taken from the UNICEF UK baby friendly initiative. So I just want to focus. I'm not going into detail. So this is just to show like this can be included in the counseling guide, like the IEC material which you are using, which any healthcare providers are using to counsel the mothers, and just check whether they have known about enough about this breastfeeding practices or not. So these contain the like question. This is kind of checklist uh, to counsel the mothers about the most common problems which they encounter, whether the baby has fed completely, whether the baby has fed enough, whether the milk production is enough or not. So this like include all this, like your baby has, how many times it has feed in 24 hours. And the last session also someone asked like how many. So it's basically on demand feed, but the count should be like 8 to 10 feeds should be there, and apart from the day 2 to 3 should be in the night time also. And the color of the skin, then how many times the diaper is changed, a separate checklist also can be there, like if the baby is 1 to 2 day old, how many wet nappies and how many dirty, when to seek the uh, healthcare consultation. So this is a very beautiful chart telling from the 1 to 2 days to the 28 days of the first. This is for the first month of the neonate. Then I'll just share you one story which I found during the my primary care practices when I was posted at the PSC. So I used to keep these chart to counsel a mother, because one of the common uh, almost like majority of the women have this complaint, like my baby can't be getting very much. It's frequently requiring the feeding. The baby is crying. I must not have enough milk, and whether this is normal or not. So this I used to tell for the behavior change, not just providing the knowledge. Like on the day of one, so this is the size of the baby's stomach, like size of the raspberry or mako. And day two, it's a size of bear. And at 1 week, it will become to the size of chiku. And at the 1 month, in the after the completion of 1 month also, it will be of the size of the egg only. So what do you think? So I asked the mother's question, what do you think, like how much, how baby can fed in a one sitting? So the answer lies in themselves also. They like understand that the baby's stomach capacity is very less, so that's why the feeding is so frequent, and the each session is very for the less time. And they can check with the various other parameters, like urine frequency, how much the baby is passing the urine, and how much the change of the diaper frequencies, to check whether the baby is getting the enough milk or not. Then strategies which can improve the breastfeeding outcomes post cesarean deliveries. These are the first skin to skin contact protocol, which can be a mandate. And actually, we can use a checklist kind of thing, and which can be stick to the walls of the this postpartum care room after the delivery. And this counseling, this presence of supportive companion should be there at the time of delivery. And the type of anesthesia, this also plays a very important role nowadays. Like even if they require cesarean section, that is done under the spinal anesthesia. So baby can be fed on the table itself. So there is no such provision like they have to wait and till the mother is shifted to ward, then they can initiate the this breastfeeding. So it's as early as possible, the initiation of the breastfeeding should be done. Then post surgery lactation support and the counseling can be done. So in this like breastfeeding techniques can be assessed by the staff nurse or the ANMs or the trained counselors, or RMNCH plus A counselors are also posted at the primary healthcare levels, so they can just see and evaluate whether the mother are correctly holding, like positioning, latching, suckling, and swelling. This again I will be discussing in the upcoming slide. So these can be assessed, and then and there only they can provide the corrective steps to the mother and empower them for the further breastfeeding, like correct breastfeeding techniques. Then the training of the medical staffs, even if they are well trained, some reinforcement training sessions can be done at the frequent intervals, like yearly once. They can be again like reinforce about the training and to provide the proper breastfeeding support to the mothers immediately after the delivery. So we have done a study and we have found, like when this breastfeeding counseling about these breastfeeding techniques and these done at the time of ANC, immediate postpartum, and after like 1 week. So the best results are observed when the counseling is given in the at the antenatal time, uh, followed by the immediate postpartum. So at the antenatal period is a very what I can say, it's a best time to provide the counseling of the breastfeeding practices, and this become very important for the primary para mothers, those who are first time becoming the mothers. And removal of any physical barrier should be there, and addressal of the like some social or cultural practices. This can be done by the healthcare professionals immediately postpartum. So these are the hunger cues which already discussed by Dr. Anjana. So I'm just emphasizing here again, just you can include these pictures in the IEC material to counsel the mothers in a better way, and just tell about the mother's preparation, like adequate hydration should be maintained, and for maintaining adequate hygiene, they should wash their hands and soap with soap and water, and dry them, and then find a place where they can be comfortable and breastfeed the child. So after removing the blanket or bed sheet covering the baby, and removing the caps and socks, in the winter time they can just dress the baby in some warm cloth to breastfeed. And this must not dress the baby with the thick cloth, because that again will be a barrier for the skin to skin contact. So this should be maintained, the skin to skin contact of the mother with the baby, to increase the bond. And these breastfeeding technique already like covered by the Dr. Anjana, but again I just want to emphasize because they have a very like important role. I'll just tell you, we have done a study, and we have taken the anthropometric parameters. We have taken the weight, height, and the age. So we have calculated all the acute parameters of malnutrition, and we have calculated the chronic parameters of the malnutrition. So even after the 6 month, that is up to the 2 year of the age, the breastfeeding play an important role in affecting the chronic parameters of the nutrition. And they are not might not have much effect on the acute, but the findings were statistically very much significant to the chronic parameters, like the stunting and underweight. So these should be corrected. And again, second thing is for the supportive supervision, which is provided by the healthcare workers at the after the time after the delivery, immediately postpartum. So they should at least check the position, attachment, sucking, and swelling, and then correct take the corrective steps to tease the mothers. So position should be well supported. I'll just quickly go through these slides. Baby should be well supported, tucked against the mother's body, lying on the side, and nose to nipple should be there, and mother should be confident of the handling the baby. Then about the attachment, it should be positive rooting reflex should be there. The mouth should be wide open, and baby achieving the quick latch with the good amount of breast tissue in the mouth, and baby stays attached with good latch throughout the feed. Then suckling, the baby is able to establish the effective suckling pattern on the both the breasts. Initially, the rapid sucks will be there, followed by the slower sucks with the pauses. And baby should end the feed, and the swelling should be there, and the swelling should be audible regular and soft swelling. No clicking sound should be heard. So I'll discuss these positions. So already been covered by the Dr. Anjana. Here I just want to emphasize when to use these position, like cradle hold in this baby lie horizontally, and this is best for the mothers who are confident with the latching, and is preferred for the full term babies without having any type of feeding difficulties. And that only limitation is may not give enough head control for the newborns. So this again, like this cross cradle hold, this is removing the limitation which I said, the head control. This is there in the cross cradle. So now it will be the become best for the preterm babies, which offer the better control of head for the latching. Then third hold, this is a football hold. So this is most commonly can be used by the mothers after the cesarean section to avoid the pressure on the incision, and mother with the large breast also, and twins also. In case of twin delivery, the football hold can be used to feed the babies. Then this fourth one is the side lying hold, and this is best for the nighttime feeding when the mother is tired, or it can be also used for the post-cesarean mother for avoiding the sitting pressure if mother is having some sitting pressure, and help in recovering from the difficult deliveries or just stitches. Then this laid back or biological nurturing position is there, and this is best for promoting the skin to skin contact and early initiation of breastfeeding. And those babies which have a difficulty in the latching, or this is a very good position, and it can stimulate the rooting reflex also if that is not properly developed in the child. Then there is the upright hold or koala hold. So this is best for the babies with the reflux or having some ear infections. And because as you can see in the image, it help it the baby is in the upright position, and baby also feels the comfort. And this is usually done for the infant having age of 3 or 4 months or more. And baby with the tongue tie or airway issues, this is the also a helpful position, because in this the gravity also plays a role in the sucking and swallowing of the baby. And rest, like as Dr. Anjana has said, the mother should try different positions. So whichever is comfortable, apart from these like 4 points which I have told: position, and suckling, swallowing, and latching. The comfort should can be added as a fifth point during the counseling of the mothers. So breastfeeding support interventions, these are the simple, scalable, and sustainable approaches. The older one which already are existing are skin to skin contact, rooming in, counseling, lactation support, BFHI, this baby friendly hospital initiative, already been covered in the previous session by Dr. Anjana. I just want to highlight this implementation of this IMS Act, this Infant Milk Substitute Act. This and this focuses on the ending the inappropriate marketing of the food or infant, and ban on unauthorized labeling of the product, including the complementary food. Second is restriction on the sponsorship, gifts, and fellowships to the healthcare providers, and a ban on the supply and distribution of feeding bottle and food, like I'm not just publicizing the name or promoting. So you can find various options in the market. And ban on advertisement of the bottles by print media, by electronic media, or any of the other media. And newer like techniques which can be used, and which are like very like helpful and give a positive result in the breastfeeding outcome, is a one of them is a video assisted counseling. Like short video in a local or vernacular language can be created and can be delivered by the kind of text message, or a link can be shared uh, for the same, to counsel the mother about the like various practices, various techniques, various problems which can act as a early warning signs, like when to seek the healthcare service providers. So this can be done, and this we have used, and we have seen, like those who are not given like video based intervention, and those who are given video based intervention, there is a median survival time of like 15 to 20 days more in those who are given this video based assisted counseling. And then on table breastfeeding in the OTs, this can be like done. Then third one is supportive supervision post delivery by the trained healthcare workers to correct the breastfeeding techniques or any problem if that is there, to like resolve them with the mother. Then sustaining impact, these all techniques will work best. These all we have discussed, these will only work when they have a sustaining impact. For this, one can plan QI, quality improvement cycles, like plan, do, study, and act. So these are the four steps of this quality improvement cycles. These can be tested for the in the maternity wards, like planning, doing, and just analyzing like what all are the lacunae, and then again plan and just take the corrective measures, or just do any necessary changes, and then again just act and implement those strategies. Then collection and analysis of the data for the monitoring the trend, and the indicators also can be used. Measurable indicators which can be used for this seeing the results of these strategies are the percentage of the newborns breastfed within the 1 hours, then percentage of the infant exclusively breastfed at the 6 month. Also like another parameter is the percentage of the mothers receiving the lactation counseling at the discharge. These all are the measurable indicators which can be used to assess the outcome. Then supportive supervision, then policy support can also be there. Then community engagement for the long term outcomes by organizing the sessions in which the community also will participate along with the healthcare providers at the grassroots level, like ASHA, ANM can also be a part of that. And small evidence-based interventions, when implemented consistently and monitored through quality improvement cycle, these can transform the breastfeeding outcomes and leave a lasting impact on the child and maternal health. So this is kind of QR code you can just refer. Due to shortage of time, I cannot play the video which we have used for the counseling the mothers in a Hindi languages. And that has also, again, I just forgot to share the results. That was also very much helpful in the mothers to improve their breastfeeding techniques and a longer lasting of this exclusive breastfeeding, and not shifting to the other artificial feed or formula feed. So thank you.
Thank you, Dr. Mohit. You have really, summarized what quality improvement initiatives any healthcare provider at their workplace can incorporate and can proceed with. You have additionally told us about the video assisted counseling and IMS Act, and definitely all the healthcare providers should promote only breastfeeding at least for the 6 months. And if at all something is required, we have experts in our field which can definitely diagnose and treat the condition. So do not hesitate to ask query. Once you ask query, then the solutions are available. So now the forum is open for question and answer. If there are any questions, we can take one by one. Yes.
I am just checking, ma'am.
Yes. Till that time, as participants are using their chat box to type their questions, I will show you how quality improvement initiatives has been recognized even by government of Maharashtra by starting the MA program, Mother's Absolute Affection program. It is identifying all the 10 steps which were given in the 2018 for the baby friendly hospital initiative to promote breastfeeding and to debar all these um, maleficent activities which were happening in the institutes. So how they are complying with the breast milk substitutes, how they are passing the resolution, what are the training sessions. These tallies are surveyed every year, the reports are submitted, and out of that, the institute which is performing very nicely on all the 10 steps to promote the breastfeeding, they are eligible for the award from Government of India. And that institute, that sector, the clinic is get a recognition that it is a baby friendly hospital. Okay, so this is the MA guidelines which has been added in the 2020. You can definitely apply for it if you are working in an institution. Okay, I just wanted to share with you. And I think in the past session, someone asked where they can get more resources, especially for the counseling. Yes, definitely they can get more resources from the BPNI website. If you want, you just type it on the Google BPNI, and you will get lot of resources for mothers, for public, promotion, for publicity, for counseling. Okay, so all of you can get videos, flyers, posters, quizzes, FAQs. You can download it. It is free of cost from there. So, do we have any question?
No, ma'am. I've just checked. There is no question as of now.
But yes, there is an appreciation post from Dr. Shafali. She has appreciated that this has been very concise and very informative. Okay, so thank you, Dr. Mohit.
Thank
Any
you.
more questions or any discussion point? Okay. So as I see, there are no questions from the participant side. Let's start moving to the concluding part of the webinar. I invite Dr. Ria to start with the concluding part and start with the vote of thanks and valedictory function.
Thank you, Dr. Bhanupriya. And am I audible? Is the network okay from my side?
Yes.
Okay, then I'm proceeding. Hello, I'm Dr. Ria Roy, current President-elect of ISCFM. First of all, I would like to formally greet everyone present today. Thank you to all the viewers, attendees, and the members of ISCFM who have joined us and gave that valuable time to our webinar. After a long time, we have again started our webinar series, and this particular webinar series is about encountering and managing common OPD problems. So for primary and the family physicians especially. So for today's webinar, I would like to thank first of all Dr. Anjana Pradeep madam for giving such an insightful dive into all these health issues that a new mother faces, the pathophysiology of those health conditions, and the care she and the baby can receive right after delivery, and cross all the hurdles to cultivate the best possible practice of breastfeeding from early initiation till after the complementary feeding starts. So you talked about the baby-friendly hospital initiative, sensitization during the ANC year, and the elaborative management for the common problems during breastfeeding. So thank you so much, madam, for that. As we know that this year, WHO and UNICEF have urged countries to invest in the health systems which support breastfeeding. So the theme was prioritize breastfeeding, create sustainable support systems. It is a theme of this year's World Breastfeeding Week. So the role of a family physician in supporting the mothers have been illuminated greatly by Dr. Mohit Bhardwaj, who also delved into the specifics of breastfeeding with the importance of like video assisted counseling, older and newer techniques of the interventions that he mentioned, while sustaining their impact through quality intervention methods and supportive supervision. So that was very enlightening. So thank you, Dr. Mohit, for your contribution. Next, I'd like to thank our moderator, Dr. Bhanupriya Pande, for the support and effortless coordination among all of us, being everyone here, by being so much involved in our activities, the ventures of ICSM. So, towards providing crucial support in academics and always being with us at the beck and call. So we disturb her a lot, but I'm really glad she's there because she's a really great moderator, and in the future, I hope she can be a really great speaker for us. So I would like to thank her. And next, I would like to thank our core committee members who have taken up the responsibilities for leading this association since last month. That is Dr. Venkatesh Kartikeyan, Vice President, Dr. Mohit Bhardwaj, General Secretary, and Dr. Haripriya H, Joint Secretary of IACFM. Sincere thanks to the guidance provided by our previous core committee members, Dr. Rubina Saha, Dr. Abhishek Rath, Dr. Teja, and Dr. Sagar, for being there with us during the last few months and helping us reach this day and event through some really big changes. Speaking of the big changes, we have just going topic for 1 minute towards IACFM. We have just finished recruiting for the nominees of the treasurer post, and by this Saturday, all the members of IACFM will be updated via mail about the election, which will be conducted next week. So details will be provided via mail also about our new executive members who will be joining us from next Monday to take ICFM to new horizons. And I'm very cognizant of everyone's patience as we get to complete each stage meeting the required objectives one by one. So with support from all of you. We ask you to bear with us and we'll keep you updated with our next activity once the election process is over. In the end, I would like to thank Learnet and especially Shomi and Rimpa for providing us with this excellent platform for the opportunity to connect with everyone who gave their valuable time and energy to this webinar today. We hope to connect again with Learnet and build a relationship by conducting further activities for ICFM. So with this, I conclude my part in this session. Once again, I thank everyone who's present here. I now hand over the session to Rimpa. Thank you.
So thank you so much everyone for joining this session. Clanet is really glad to have all these brilliant people together. So with all your permission, shall I close the session for today?
Yes, sir, Rimpa. If
Yes.
everyone is okay with it, then we can close the session.
Sure.
Okay.
Okay. Thank you, everyone. Thank you. Good night.